If you're finding value in our episodes, please pause to give us a rating and leave a review. Your feedback is crucial for helping us connect with more listeners. Thanks for your support. All right, so we are bringing back our best friend. I think she's our best friend, Emily Evans.
I'm your best friend.
Vic is on vacation. He is enjoying a wonderful cruise with the family, and boy, did he miss a week. Boy, did he miss a week. So, sometimes these things just work out perfectly, and it was great that you're available because I can't imagine anybody else I would want to try to talk about what has happened over the last, not even 7 days, 5 days but we're not going to rehash a bunch of stuff that you can get on, pick your news channel or your publication. We're going to talk about healthcare.
Yeah.
We're going to talk about healthcare.
I've been thinking about that this is going to turn out this way for several years now, which is that the Biden presidency would be in trouble. I thought he was going to drop out earlier because he's not a great candidate, which kind of makes you wonder how well he's handling the burden of the presidency. But it took us a while to get here, and where we are is that you have to very seriously consider that we will have a Trump presidency.
It is time to very seriously consider that, and this week especially, right? I feel like next week is going to be a very different week for many, many different reasons.
Yes.
And I think we will start to have a lot more focus on what the Democratic Party is going to do next week. But this week, we are in RNC week, and we just had, thank God, an unsuccessful assassination attempt on President Donald Trump.
Horrible.
And so he survived and really was not very injured at all, which is, maybe other than, holy shit, I just had a serious rifle bullet.
There's some luck there. A lot of luck there.
Whizzed right past my head.
Yeah.
But that aside, it is a time to really think about what a Trump administration would mean for the future of healthcare. And I just want to this is episode 74. Vic and I were talking about it maybe 2 or 3 episodes ago after Chevron went down with the Supreme Court.
Right.
We called back to our audience that on episode 2 of this show, we had you on to talk about the Chevron deference doctrine. Right. Episode 2. Yeah, okay. Way before anybody else was talking about it, right? We were talking about it. And lo and behold, now there's this. Now everyone actually knows what Chevron is, right?
Yeah.
So we feel it's important to at least get on record what are the key areas of healthcare that are likely to be impacted if the administration does change, right?
Yeah. It's a way to think about it.
Yeah. So you did some good work on this, and we're just going to kind of treat this like you did this work for Hedgeye, but you're sharing it with the Health Further audience, which is really sweet.
Right.
But we're just going to kind of treat this like as if you were presenting it to Hedgeye, but Hedgeye is me for now. And I'm just going to ask you questions, and we'll kind of go through it. So is there anything you want to say at the top before we start heading through this?
I think that the top line thinking on this issue, this problem, whatever you want to call it, is that the deficit and the debt of the country has gotten to a pretty untenable place, right? Mm-hmm. Healthcare is a big chunk of that.
And a growing chunk.
And a growing chunk. And so that makes people, investors, market, industry people think, all right, the answer is going to be to cut healthcare. Well, if you think about that for a minute, you realize, well, if you cut healthcare, you drive the country into a recession.
Right.
Okay? Even though that might be a good idea over the long haul, if you're a president or a member of Congress, that's not a great idea in the short haul. So then the question becomes, all right, what can they do? What should they do? What's possible? And we have a lot of sources of information for that. The House appropriators have been signaling where they want to go. The Trump campaign has been kind of light on details, and the Heritage Foundation has produced a fairly substantial white paper.
They are not light on details.
They are not light on details. And then there's other think tanks have also weighed in.
Sure.
And one key part of understanding a Trump presidency and with respect to healthcare is that Donald Trump's two biggest economic advisors are Steve Moore and Art Laffer. And Art Laffer and Steve Moore both understand that to reduce the deficit, this is the Reagan formula, you grow your way out of it. If you go through the austerity thing, you end up like Europe. Okay. It's just math, really. So that's kind of the top line way to be thinking about this.
Okay. All right, great. So let's just start with the view of where healthcare as a percent of GDP is today and where it is headed according to the HHS Office of the Actuary.
Right, and you'll show this chart for people who watch the video, but this is the micro problem of the macro problem. The macro problem being the deficit and the debt, and associated with that problem is, of course, the growth of healthcare as a part of GDP. Simply because we're printing money and we're transferring it from the U.S. Treasury to the healthcare industry. That's what we're doing, and it was pretty steady at 17% until COVID, which rocked it up. And now it's predicted to go up to 19%. And keep in mind, that doesn't count a lot of things. It doesn't count construction of healthcare buildings. It doesn't count consultants and so forth. It's really just payments.
It's just payments. That's just payments.
Just payments. Yeah.
Wow.
And that's a big, you're 20% of GDP. That's a big number.
Yeah.
And the question is, all right, what is the president likely to do?
Yeah. Okay. That kind of sets the backdrop, right? It's like you're standing on the train tracks, train's coming at you, and a large part of that locomotive is healthcare.
It's healthcare.
A large part of it. And you have to do something about it.
And
right?
you can't just simply cut spending.
No. In fact, Vic and I were talking about the first draft of the proposed physician fee, kind of going down. And we were just talking about how chaotic that felt. Just to kind of see that you're proposing you're going to pay physicians less.
Right.
You know what I mean? Like,
well, and that's a statute. That's something they're following the law, and that's a statute. But and they have to do it. But what it's doing is it's pushing people out of the program.
Of course. Of course.
And that is chaotic. And
that is chaotic.
Not, again, that's not something you want as a policymaker.
Right.
So
so framing up the direction of the policy, you've kind of got the good, the bad, and the unknown.
You're right.
Okay, so let's start with the good. What is in the bucket of the? First of all, when you say the good, the bad, and the unknown, what do you mean?
In that case, I would say the good means that the policy direction is a tailwind.
Okay,
it's going to be a general positive for a subsector.
Okay.
When I say it's bad, it's going to be a headwind.
Got it.
In some cases, hurricane force.
Okay.
And then when I'm not sure, and I call that the unknowns, because there's so many puts and takes and, offsetting concerns and some unknowns, I'm not really sure.
Okay.
So I call the good is ambulatory care. Cheaper sites of service, patient preference, all those things that make ambulatory care more attractive than inpatient acute care.
Sure.
And everything that goes with that. Okay. And then the bad, nonprofit hospitals, which has implications for major equipment expenditures and so forth. Large biopharma, so that's your Merck, your Pfizer's, your, GSK's, et cetera. The larger reference labs, of which there are only two, LabCorp and Quest. And then the biotech research and discovery. So early stage biotech, so preclinical and maybe even early clinical, we've got some pretty decent headwinds. And for me, the unknown is managed care, how that turns out. It's hard. There's some good things that are being proposed, and then there's some negatives, and it's really, these are very nimble organizations, and they're able to wade their way through it. And managed care organizations happen to be very data-driven organizations. They look at they're actuaries.
Yes. Yes.
They can see the future, unlike most of us.
Okay, so really quickly before we move on, I want to understand a little bit more about maybe specifically biopharma, just because I think one could say, looking at the agenda that the Biden administration has taken on, especially over the last 24 months, with, hey, we're going to negotiate drug prices. Hey, we're going to, just some of the things they've been really trying to push. Is that a consistency of a tailwind, or is it a tailwind for a different reason?
It's a headwind.
Sorry,
yeah.
Is it a consistency of a headwind? Is it a headwind for a different reason? Is it a different part of biopharma's business is going to be attacked from a headwind perspective?
Think of the top line first. The problem biopharma has is that they really ran out of ideas quite a few years ago. Humira was like the last big hit, which is a fantastic drug.
Well, hold on. I mean, the GLP-1s are those are a big deal.
They're a big deal, but those are ancient molecules.
Of course,
There wasn't a hell of a lot of innovating going on.
Okay. I understand what you're saying.
Put these two things together.
I get your point there. Okay.
But it's a very crowded space already.
For sure.
So they ran out of ideas, and what they have done, and this is what's attracted so much negative attention, is to make up for the lack of organic growth in their industry, they just raised prices and engaged in a lot of goofy stuff like rebates and so forth that have gotten them the attention of Congress, and ultimately the Inflation Reduction Act, which created the price negotiation, which I will point out that the price negotiation between the government and biopharma, that is the price to the government. That is not the price to the consumer.
No.
And everyone assumed their prices would go down. They're not.
Yeah. Okay.
So that's the top line problem. And then as you move down, as a result of that just natural problem, we're not innovating. We don't have any good ideas. Those things that we want to explore, like Alzheimer's, we keep ending up down rabbit holes. They don't work and they kill people. And so they raise prices, and they also start chasing crowded things like GLP-1 drugs, vaccines, for which you don't actually need to have all of your ducks in a row in terms of safety and efficacy, because you have no liability. And that's created.
It's kind of the fundamental that business model there.
Well, that's the balance, right? I'm very, very careful about creating this drug, because if I'm not, I'm going to end up in court. And the pharmaceutical industry is trying to. The pharma, the big lobby organization, is trying to convince Medicare to change some of the rules around the Inflation Reduction Act. And so in order to convince them, they pulled out this list of pipeline. It's almost all vaccines, or what they say are vaccines. It's all vaccines. And it's like, okay.
Now, not all pharma companies are vaccine heavy in their roster, but there are some that are very, very, very vaccine heavy.
The point is the pipeline. All the R&D is going into vaccines. At the same time, you have the president and J.D. Vance, the prospective vice president, saying we need to take a really hard look at some of these approvals. Yeah.
And obviously J.D. Vance, with his background and history, he's got sort of the personal story.
He's got a natural suspicion of the industry. And they're not doing themselves any favors, because GLP-1 drugs, how much is that a month? $1,200, right? For molecules that we've known about for forever and ever and ever.
Yep. Okay.
And that's the concern there.
Okay, that's helpful. All right, so if we're talking about managed care organizations, as you said, they're not what they used to be.
No,
they used to just be actuaries.
They're little governments.
Yeah, they used to just be actuaries. Now they're like. I mean,
they do housing.
They do it all.
Grocery shopping.
They do it all. They do it all. Yeah. So they definitely have lots of ways to hedge headwinds, and offset things to kind of keep them moving forward. UNH had a positive result, and stock prices sort of back up, pulled the rest of the managed care stocks along with it. Okay, so just talking about Medicare and Medicaid and then ACA and other, let's go through Medicare, because Medicare has been a bit of a roller coaster, right? The Q4, it felt like, oh my gosh, all these headwinds. Then they went to court, they lost in court. Yeah. So, but they've raised premiums.
Yes. So there's I put managed care organizations in this kind of unknown category because it's hard to see exactly how. First of all, we don't have certainty on all of the policies, and second of all, it's hard to see exactly how one policy and the integration with other policies might actually affect the sector.
Yeah.
So so that's the way to approach it. It's like not really clear, but in the positive category, the Trump presidency, as Trump won, I call it, was very much favored Medicare Advantage, preferred that to be the default option.
Okay.
Probably will revisit that. That is
Okay.
very different from the Biden administration, who wanted fee for service to be the default option.
Yeah.
And it still is. So that's a positive. Getting rid of some of the regulation. A lot of the managed care organizations have adopted, policies and have been encouraged to adopt, different programs on social determinants of health, which you just mentioned.
Yep.
Health equity, which is poorly defined in many cases, and it's very likely that will go away. We'll just deregulate that. They also, so that's a positive, I think. Greater flexibility for sites of service, being able to let a patient pick with their doctor where they're going to have a procedure done. That's also a positive. But, revamping the bidding system, which is something that they want to do right now, is a very difficult formula. It's not really quite a competitive bidding process like I think it was originally envisioned. That could be a real headwind. In Medicaid, the flexibility, the greater flexibility of states to do block grants and so forth, which is part of the proposed policy, that could be a positive for managed care organizations because, the money would go from the federal government to the state would throw in their money, and then that would all go to a managed care organization, which would then be able to allocate appropriately. One of the difficult things about Medicaid is it heavily favors care in hospitals and skilled nursing facilities. Doctors hate it. And so you don't,
and they're not taking it.
And a lot of them don't take Medicaid. And so that kind of block grant thing would be beneficial. At the same time, if you end these supplemental payments or state-directed payments that you'll see a chart. I'll show a chart in a minute on that. It's that could be a negative, but it depends on how they put those two things together.
Right?
How do you put together a block grant program? And by the way, Tennessee has a block grant program, and it seems to be working pretty well. How do you put that together with an end of supplemental payments? I believe what'll happen is, in order to get governors to play along with block grants or per capita numbers or whatever, then those governors would say, all right, I don't want any deterioration in my total funding.
Yeah.
And that would get them to go along.
You'd have to increase what was going into the block grant.
Exactly.
Because,
you need to have some incentives.
Yeah, because as we'll talk about later, supplemental payments are not inconsequential.
No, they're not.
Right.
Work requirements, that was something that was discussed on the Trump administration in the first phase, and Indiana has a fairly decent program on that. One thing that is a positive is there's a possibility this would have to happen with Congress is you end the state plan amendment process.
Okay, and where'd you get this from? Is this Heritage?
This is a combination of Heritage, appropriations, and some bills that have been considered on the House side. Primarily.
Okay, got it.
I'm just mashing them up.
You're pulling it all together. Yep, got it.
Mashing it up.
Okay.
And then for the managed care and the ACA, I think the biggest worry there, Marcus, is the fact that there appears to be a decent amount of fraud in the program. And
in the ACA?
Mm-hmm, and a lot of business practices that aggressive marketing practices. So people are turning up having been enrolled in an ACA plan that they didn't enroll in.
Oh, okay.
And because the way the Medicaid disenrollment worked post-COVID, there were all these mechanisms in place. So-and-so is no longer Medicaid eligible. All right, we're going to give their name to the managed care organization or whoever their third-party marketer is, and they're going to sell them an ACA plan so they stay insured. There's a lot of hanky-panky that can go on in that system. And it appears
I get that.
It appears that that's the case. Getting rid of the family glitch, which was a policy in the ACA said if you have to pay more than 9% of your household income on to health insurance, well, then you're eligible for ACA, even though you're employed. But that didn't include your whole family, okay?
Right.
Well, they revised that, and this is definitely Chevron deference territory. They revised that and said, no, yes, you can have your family enrolled,
and voila,
like, magic,
all sorts of new enrollees.
Forget about that law thing over there.
Yeah, all sorts of new enrollees.
Yeah,
okay,
yeah.
got
So
it.
it's they're, like I said, they're puts and takes on that one. So we just really need to watch it pretty closely.
Okay, all right. So really quickly, because this is pretty wonky stuff, but there is something going on around Part D plans,
right,
and the premiums and rebates.
All right, and this is a catalyst. Right. This is a catalyst because what's happening is the Inflation Reduction Act, just to give you the punchline, is driving up premiums in Part D plans. And
that's unintentional because it is the Inflation Reduction Act.
It is the Inflation Reduction Act, but it's actually going to cause inflation. So you're going to probably see a doubling of Part D premiums in 2025.
Wow.
They're underway right now.
Wow.
You've already seen, if you look at Humana's per member per month, which from first quarter, you already saw a pretty big jump there, and you're going to see even more of that in 25. That's a crisis. That's we got to do something. All right, and there's some administrative things that can be done nearly immediately. But the bottom line is that you cannot outsmart the drug industry or the managed care organizations, and it's causing, and we're in the very early stages. There's not a lot of people understand that this is going to be a problem.
Yeah.
But it's going to be a problem, and once you open up that section of the law, everybody's going to come in and want to make their own revisions. And MA, PDP enrollment, prescription drug plans, standalone plans have been in decline. If and I showed you a slide on the that shows that there's been this decline in the number of enrollees in standalone PDP plans versus Medicare Advantage plus a PDP plan. And that's because the managed care organizations are saying, all right, more people need to be in MA plus PDP. That's better for us, and it's better for them. And that's kind of reversing itself because of this Inflation Reduction Act thing.
Okay. Let's see. Medicare Advantage enrollment forecast.
Right.
So that is right now looking like it is declining.
It is declining.
Okay.
And a lot of that has to do with, and you've heard Humana say this, that has to do with managed care. Managed care organizations are looking at demographics, the last of the post-war cohort, 1961-62 birth year, turns 65 in a couple of years.
Okay.
Which is not a very long time in health insurance. And so you're going to have less people to sell to.
Right. Okay. Like they're all going to be there.
They're already there in the program.
Yeah, they're there.
At the same time, you have the biggest group cohort in post-war generation, 1947. Yeah. They are 78 years old.
Yep.
And what happens when you're 78? You start to break.
Yeah. Well, that's our life expectancy.
That's you're gonna lose. People require more health care.
Yeah.
So on the one hand, you're getting less people coming in.
On the other one, they're getting more expensive.
They're getting more expensive.
Right.
So what's happening is the Medicare Advantage organizations are like, okay, let's just step back and make sure we're enrolling the right people at the right price. Okay.
Yep.
And we're pricing properly.
Yep.
For years, Medicare Advantage plans could be nearly free, for a lot of people, or some very nominal amount of money for a lot, not everybody, but for a lot of people. And now you actually have some pricing going on, and that's going to make a difference in the choices people make. Now, offsetting that is an administrative policy potentially that wants to make Medicare Advantage the default. So when you turn 65, instead of opening that envelope that says "Welcome to Medicare," traditional Medicare, you're going to get this note that says, "Which plan do you want? Do you want Humana? Do you want whatever?" And so that again, that's a great example of there's this bad thing that's a headwind, and then there's this potential good thing that's a tailwind.
Okay. Okay, let's talk through this supplemental payment breakdown. Yeah, I know. Well, first of all, I don't think every one of our listeners will understand what supplemental payments are. I have to fully admit, the beginning of this year, I didn't fully get it.
Right.
I do now, but someone had to sit down and actually draw it out for me because it's like it's a rope-a-dope of that the money goes here, then it goes here, then we ship it back here, and and in the end, the hospital gets made whole. Right? Yeah. Exactly. They get made whole. So
the way to think about this, even if you aren't deep in the weeds on this stuff, is that for most of my career, your preferred payer mix, if you're a hospital or a nursing facility or whatever, is commercial, biggest piece.
Yep.
Then Medicare, then Medicaid.
Yep.
Okay. And you always wanted that mix to be tilted more towards commercial.
Yeah.
Supplemental payments are designed by the states and the federal government in cooperation with providers. And this is perfectly legal. There's nothing funky about this.
Yeah.
I mean, there's nothing underhanded about this. It's just the way we designed the program.
Right.
They have set those states, and with the agreement of the federal government, have said, okay, if you're a hospital and you want to tax yourself, you want to raise your bed tax so that can leverage a federal match. Essentially, $1 goes from a hospital into the state coffers. The state then says, hey, federal government, there's $1. Send us $1. And then $1 becomes $2. Okay, that's how it works.
Yeah.
And that money is supposed to close the gap between what it costs to take care of a Medicaid patient and what they're paid.
Right.
That's what's and the federal government has said for years and years and years, when you close that gap, make sure you're not paying more than what you would be paid under the Medicare program.
Right. Yeah. It's supposed to kind of bring you up to par with Medicare.
Yes.
Not necessarily bring you up to par with commercial.
Now it is.
Yeah, right. Exactly. Yeah.
So effective on July 9th, states could now the gap isn't between Medicaid and Medicare. You're trying to close with supplemental payments. It's between Medicaid and commercial.
Commercial.
Okay.
Yeah.
So to quote the investment relations person at a major hospital, publicly traded hospital chain, we are payer agnostic.
Right. It doesn't matter anymore.
It doesn't matter.
It doesn't matter anymore.
And this is because you've essentially Medicare is less than commercial, but now Medicaid is up at the top.
Yeah.
And it's going to explode now that you can do the upper payment limit as commercial.
And the states are not out any more money.
No.
This is a federal.
There's a federal thing.
So this contributes. I'm trying to make sure we're connecting it back to the Trump thing. This is back to the growing percentage of GDP,
right? And
also specifically the federal deficit,
right? Exactly.
Right? So it's part of
the government has to print more money.
That's right.
In order to pay money, the federal match to the state,
right?
And it's something that, on a bipartisan basis, people have said it's this terrible way to do business. But if we get a block grant proposal, or as states come in to renew, it's very possible that the government says, "All right, no more supplemental payments, but we'll make you whole with in a block grant or a per capita cap or something like that."
Yeah,
which you would love if you're a governor, because you're tired of the lobbyists crawling all over you.
Yeah, but it's no less money that you're receiving from the
You're
feds.
never going to get the states to go along.
Yeah,
unless
the money is on par.
It's on par, and it inflates at a level that matches what your expected.
Yeah, but
trend is.
What is likely to happen is this new caveat of, hey, we can go right to the ceiling of commercial. That gets pulled back, right? So
I don't know if it will, because it's there now.
Okay. Wow.
And what I would and the policy objective is to end the state plan process, this 5-year re-up of the
Right.
Medicaid program, and to end this
Because it's bureaucratic. The thinking there is because it's bureaucratic.
It's bureaucratic, and it has teams of people doing nothing but updating.
Okay, so expensive in that
plan
way.
amendment, and the premise, the subtext, if you will, of that policy is these 50 governors, you don't know what they're doing, and in 1965 that might have been a concern,
right? Right.
But they all have very sophisticated programs, and there's just no reason for that to happen.
This is just another one of those examples of like the law hasn't caught up, right? I mean, we have AI being regulated by a Medical Device Act from the 70s.
That's right.
Right. Okay, got it. So, but for the listener who is not viewing, the chart details the supplemental payments are 20% of total Medicaid payments to hospitals from fiscal year 2022. So this is not an insignificant percentage of the money flowing into hospitals.
No, it's not.
And I think just last thing I'll just say is particularly for nonprofit hospitals, because they are the ones with the payer mix that is really, really heavy on Medicaid. Right?
Because they're that just because of their patient trend.
Okay, let's talk about ACA marketplace enrollment. So the family glitch, which basically said, hey, it's not just about you as an individual, now your whole family. So everyone just got their whole family. Yeah. So ACA marketplace enrollment has really had a pretty huge year-over-year change from 2023, 2022 to 2023.
Right. And
not something I was aware of, actually. I didn't know that.
Yeah, and this is actually using my estimates, my model for determining ACA marketplace enrollment.
But your data source is HHS, right?
My data source is the Office of the Treasury.
Okay.
And what I did is I built a model based on Treasury outlays and historic behavior to guess as the enrollment.
Okay.
My enrollment number is a little bit lower than what the ACA plan selections we were told they were in January. So if you were to add what they say, which I don't think is accurate, but if you add because it's just plan selections, it's not people who actually paid their premiums. You have a huge jump in the number of enrolled people.
So what would the Trump administration say about this? You said they want to roll back this family glitch.
I think that because the law does not. We had interpretations from President Obama until the middle of Joe Biden that all said, the Department of Justice said, no, you can't do that. So I think the first response is, well,
was there an agency that made this change? Was it CMS?
Yeah, it was CMS.
It was CMS.
But with the Department of Justice suddenly saying, "Oh, never mind all that,"
Okay,
you can do that.
So does this flow into Chevron?
This is definitely a Chevron.
This is just Chevron issue. Okay,
because the law is fairly. It's poorly drafted. The whole law is poorly drafted. It causes problems left and right.
Yep.
And this is an example of it being poorly drafted. Did the drafters envision a case where you would have a head of household who was employed, who couldn't afford the employer-sponsored insurance because it exceeded 9% of their household income, and they were really thinking in their heads, this health insurance should be purchased for the whole family and not just the employee? Maybe, but it was so poorly done. We don't know, and all you got are the words on the page, and that's what the judge is supposed to look at. So,
okay, got it. So the Trump administration is likely to roll back to what was the precedent in this case.
And I think fraud, waste, and abuse is going to be a big part of this and the Medicaid program. Fraud, waste, and abuse is our shorthand for kicking in the program integrity people to audit and look at, all right, are these people really eligible?
What's the downstream effect of that? If you're in effect kicking families off of marketplace plans because they're not eligible based on the interpretation of the law, does that shift them to Medicaid?
It would probably be in their employer sponsored insurance.
Okay.
Which would be more
if they have an employer, right?
Yeah, they have an employer.
But let's take the case of a family where they're gig workers.
In that case, they would, if they lived in an expansion state, they would probably be eligible for Medicaid.
Medicaid,
expansion state, and they may, if you've got somebody who was kicked off of Medicaid, or somebody who loses their eligibility in ACA and goes to Medicaid, chances are they're eligible for ACA. I think what is most likely happening here is
This is people not doing their employer-sponsored plans and going to marketplace instead?
Yeah.
Because employer plans are kind of crap?
Yeah, that's right.
Yeah, okay.
And so they would have to, make a decision. They could possibly go to Medicaid. They could go to their employer. They're probably not who we're talking about. Who probably is going to be the focus of attention in ACA plans are people who are already covered and using whatever insurance they have and are somehow enrolled in these ACA plans.
Okay, now that's the fraud thing.
That's the fraud thing.
Yeah.
Because it's a big jump. It's a big number. And interestingly, we raised we got rid of the threshold above which the income threshold. So you can, no matter what your income is, you can enroll in an ACA plan. And that expires in 2025, at the end of 2025.
Okay.
And so people,
was that an emergency action for COVID or something? Or
no.
drove
It was
that?
a change in law. It was in the, I believe it was in the Inflation Reduction Act.
Oh.
And it essentially says that.
And it already ends in 2025?
Well, it was I think a 2-year, 2 or 3 year,
2 or 3 year program.
Yeah.
Okay.
Because it costs so much money. You can't do it for 10 years or whatever.
Right.
So the enrollment growth, all right, is not coming from people making over 400% of the poverty level. It's coming from the non-expansion states and people who are in the Medicaid zone, but they can't get Medicaid because they're in the non-expansion
states. Yeah.
So what, so it isn't, this nice family of 4 whose dad's an architect and doesn't have access. That's not what it is. It's mostly in the lower income in the non-expansion states, and there's some eligibility questions there, I think, that need to be answered. I think that's true of Medicaid as well. Medicaid enrollment is high, but it should be declining faster than it is even after disenrollment because the employment number is in pretty good shape.
Yeah.
So so you're going to see a lot of that. That is low-lying fruit. Nobody gets mad when the accountability people show up, and that's going to be an easy win to kick all that fraud, waste, and abuse, which used to run in the Obama administration. They're very serious about it. It really just fell off the truck here, recently.
Yeah. I mean, I think the Obama administration was incentivized to make sure that it worked, right? It was on their watch, got launched, and so.
Yeah, he didn't want healthcare expenses to explode.
Of course not.
While he was president.
Yeah. Okay, so now moving on to your bad category,
my bad
right?
list.
So let's focus for a little bit on non-for-profit hospitals. We talked already a little bit about biopharma, so we could probably skip over that one. But non-for-profit hospitals. It feels to me like, I don't know, the last 12 months, not-for-profit hospitals have actually had a pretty good last 12 months, I think.
Thank you, Medicaid.
Yeah. Well, Medicaid also, it feels like in the courts they've done well. They've been able to maintain the 340B stuff.
Yep.
That, I mean, the AHA has been pretty successful, I would say, over the last 12, 18 months
would agree
with their policy efforts. So I think it's just important to call that out because you're saying you believe the Trump administration brings in additional headwinds.
I think the price transparency initiatives that started under Obama.
But Trump was big on competitiveness and price transparency in term one. He basically didn't get to finish it because of the.
Thank you, Art Laffer. Yeah,
and also Larry Van Horn.
And Larry Van Horn.
And Larry Van Horn.
Yeah.
But he didn't get to finish it because of COVID. Basically, right? I mean, he was moving through it.
Yeah, and truth be told, the data was not in particularly good shape.
Okay.
The data still isn't in particularly great shape. If you go to some nonprofit hospitals, I couldn't tell you what the price is. So there had to it was a slow motion kind of thing. But the House Energy and Commerce Committee has worked on price transparency. It's obviously a project of the Trump administration. The Heritage Foundation says we need more transparency. So we're not there yet where the data is completely usable. There's a lot of problems with it, and it's evolving. But when we get there, maybe 2 years from now, when we get there, you potentially have the development of a cash pay ecosystem.
How do we get there? I mean, the Charge Master was an absolute disaster.
It was a disaster.
That was not a thing, right?
Yeah.
So what is there some innovation that's happening on the data front that is going to change this?
The first requirement in July was to have everybody build out their complete list, not just a select list of services, but the full list. And to ensure that it's machine readable.
Yeah, I remember that. But then there was like a bunch of stuff about that, right? Like the machine readability thing, right? I mean,
but it's going to have to take people getting involved in researching, and even the private sector.
I was about to say, I actually know a consulting company that has built out a platform,
right,
all around this,
okay.
and it's pretty cool. They're sucking in all this machine readable data,
right?
And it's so not machine readable that they're going to have a business, because you got to build in all the things to normalize the data, because it's kind of a mess.
Right, it is kind of a mess.
Yeah.
And it's one.
But the outputs are powerful, because you do get this ability to kind of basically put in any given market 5 hospitals side by side and kind of say, hey, these are the contracts.
Right.
You know what I mean?
But one of the problems I think that is going to be, that's going to persist, is the language of that data is the CPT code system.
Right.
And you, as an informed consumer, you're going to have to, and this is probably a moat for somebody, right? You're going to have to put in your, which CPT codes are most likely to go with other CPT codes. And those kinds of things.
So the private market thing that I was talking about is very much like an industry tool.
Okay,
a consumer can't use that.
Okay,
No.
Right. Okay.
Yeah. Okay.
But the vision is that the consumer would use it. That's the long term vision. And the nonprofits, particularly academic medical centers, always come in high on their pricing. And something like a birth, for example, you've got in Nashville, Tennessee, a pretty big disparity on a service that we used to perform in caves. Okay, this is not. It's just not. You can pretend, that you're special, and delivering babies, on 21st Avenue versus, Southeast Nashville, but you're not,
That's right.
It's so there's a big disparity there, and if as prices, and I'm thinking about this in a 3 to 5 year time frame, okay, maybe more 5 than 3, but you're gonna have to adjust. When you have any kind of cash level ecosystem.
Yep.
Or even if even if your employer starts to get interested.
All right. So I want to roll through this list of bullet points, because I would like for you to pick out the one that you think is going to be tip of the spear. So you've got price transparency, site neutral policies. That's a big one.
Right.
Elimination of inpatient only lists, kind of part 2 of the site neutral policies.
Right.
bit.
Yeah.
Expansion of ASC covered procedure list. That's also kind of built into that. Restructure of 340B program for benefit of patients. That's a big one.
Right. But only big for a few hospitals.
Well, big for a big enough cohort of the nonprofit hospitals.
Well,
I mean, that like it's a major AHA item.
It is. Henry Ford, Vanderbilt, Mount Sinai.
Yeah.
I'm trying to remember who else is. I'm not picking on anybody. They're on the list.
No. I mean, it's not insignificant.
No, okay.
It's not insignificant. And then supplemental payments, which we've already covered, and then slashing payments for refugee assistance. Yeah. We can leave that one out. So of those, tell me the one that you think is really going to be tip of the spear that they will actually try to create a public narrative around.
I think the re-elimination of the inpatient-only list, because the Trump administration, remember, ended it with a 3-year phase-out, and that was reversed.
And then brought it back. Okay.
Yeah, brought it back. So that policy is, locked and loaded.
Yep.
Right? It's ready to go. And what we did not give it enough time to do, because it was reversed by the Biden administration, we did not give it enough time to develop and allow innovation to develop and allow procedures that were considered inpatient only to develop into ambulatory procedures, through robotics, through whatever the source of that innovation. They didn't give it enough time. So if you restart,
I mean, in some cases, it's not even robotics. It's just set up a building.
yeah,
There's not that much to it for a lot of this stuff.
Once you're putting a patient under anesthesia, you have a higher order of things that you have to do.
Sure.
And you have and that needs to be considered.
Sure.
And then there's, what do you do? Who's going to take care of you and get home? And all these things that need to be considered. But the interesting thing about a lot of those procedures that have moved into ambulatory space and can move into the ambulatory space, those are big margin procedures.
Yeah.
That's where a lot of margin is.
Yeah.
And if you are left as an inpatient hospital, first of all, if you're a nonprofit hospital and you've not created that vertical continuum of care integration, like the publicly traded guys have done, like a few of the nonprofit guys have done,
and some are more moving in that direction. I mean, you mentioned Henry Ford, like they're definitely moving in that direction.
And
Vanderbilt for sure.
Vanderbilt for sure.
Yeah.
Then if you haven't done that, you're in a tight spot. Okay, because you need to do that. Otherwise, you're just going to have price pressure, and what you're going to be left with is really sick people who have nowhere else to go. Okay, which is very low margin, negative margin, type stuff. So I would say that is very much a near and present danger for the nonprofit hospitals. The 340B, yes, the American Hospital Association wants to protect it, but there's a lot of people out there who are like, wait a minute. That I paid 20% of list price. You bought it at list price minus 25%. Why am I getting hosed here? And it's and some of these drugs, these inpatient infusion, these are thousands and thousands of dollars for a session. That is all three of these are what? They are consumer friendly.
Yeah.
And what is the platform of the Trump administration? I'm here for you.
Yeah.
Right?
Yeah. I mean, day one of the RNC was make America wealthy again. So
okay, was it? I didn't see
it was. Yeah. So I'm not watching the whole thing, but I'm definitely tracking what the themes are, right? Because the themes will emerge into campaign pillars, effectively.
But you have this massive populism movement upon us.
Yep.
And
the Trump administration is definitely driving on a populist platform.
Exactly.
Yes. So that's really interesting. I mean, price transparency, site neutral policies, elimination of inpatient only list, ASC covered procedural list, and 340B. I mean, if two of those happens, I mean, much less all five. I mean, that is a really
it's a big deal.
That's a big deal.
Yeah.
That's a big deal.
And what I expect to happen, and what I predicted would happen in Trump 1, is that the for-profits would take share from the nonprofits, and I still expect that to happen. They're more cost efficient. They're adapting to technology.
Better payer mix.
And once you start going down the path as a for-profit hospital, which traditionally they didn't attract the great docs, right? The great docs wanted to be at the big nonprofit in town or the big academic medical center.
Yeah.
But once you become a great provider, and you attract docs.
Yeah.
Once you start attracting docs, really high quality docs, game over, in your market. So,
and look, I mean, I've heard so many people, experienced hospital execs, talk about how the current incentives are just not there to move the industry to a more kind of decentralized freestanding ED and then, best site of care kind of model where it's all in the same vicinity and it's all integrated through technology, but it's not all in one building, right? You know what I mean? Like that whole thing.
Yeah.
And we just have not had the market force to push and create that, right? To create that ecosystem. And you wonder how much, to your point about, you don't want to create a recession by imploding healthcare.
No.
But what happens if, the vast majority of Medicaid and Medicare is occurring in a decentralized model, very integrated, very technology enabled, but sites of care that are optimized for what they're supposed to do, right? As opposed to the whole big building,
big building
thing. Yeah. I mean, it's just a question of how much of the how much of that 17% and growing of GDP is locked up in the big building.
The stranded capital problem. And that's a good. We won't know. The only way this goes successfully is if there's a nice glide path.
Yeah, right.
To that future state.
Yes.
And if you do it immediately, you're probably not going to be successful.
But this is not immediate. What this really is creating the environment for a competitive set of companies or alternatives to emerge in which would be the glide path. The glide path would be creating an environment where competition can actually transition market from one state to another.
There is no place where you were going to find lower productivity, except maybe a restaurant, than healthcare. Hours worked produces, how many units of product. Okay. Mm-hmm. It's terrible. And it's been a drag on the economy generally. And until artificial intelligence showed up, the prospects weren't very good.
Yeah.
But if you implement these policies and you start to create a competitive environment, and people wake up to the idea that sure, your insurance covers it. That's great, but that insurance is in place of cash wages. That's the deal you accepted. You accepted, okay, I'm going to have this great health insurance, but that means my cash wages are going to be lower.
Right.
And that people are done with that.
Well, especially after 2 years of inflation, right?
They can't do it.
Yeah. It's crazy.
So if you want to stimulate the economy and the consumer in particular, get their cash wages up, and this is one way to do that.
Yeah. All right, let's see. What else must we talk about here?
Let's talk about biotech real quick.
Okay, let's talk about biotech.
All right, so biotech this has been the darling of Wall Street now for,
Well, it was until the last 3 years.
But it had a pretty good run the first part of this year. But it's been it was a darling for forever and ever. And I brought a slide that shows funding at NIH and National Institutes of Health, made famous by Dr. Anthony Fauci during the COVID. Nobody knew they were there until he started attending every press conference. It's 27 centers. The most famous is the National Cancer Institute.
Cancer Institute, yeah.
Which happens to be probably the best run one. And it has it's done. Originally, it was just basic research, doing stuff that the government, like the Human Genome Project.
Mm-hmm.
Now, what private sector company would have undertaken that?
No.
Where's the product? Where's the monetization?
Right.
Where's the moat?
Right.
And so NIH that's what they were mostly doing. As time has gone on, really becoming competition with the private sector in some respects, where they're attracting scientists that would be in the private sector to work for the government, and they're funding more applied research, which applied research is what the private sector is really good at. They can see the monetization, they can see the strategy. We don't need the government to do that,
right?
But nonetheless, what the government has done has funded early stage biotech companies indirectly and directly, and those early stage companies, they're funded at MIT, or Broad, and then that gets turned into a commercialization project of those institutions, and then gets spit out into VC land. Well, the funding for NIH has been significantly clipped by the House in particular, because of its behavior during COVID.
Mm-hmm.
And it wasn't so much, Dr. Fauci's rather unpredictable, appearances that consisted, but that have been consistent since. It's the fact that what we learned in that is that you can control scientific consensus just by making sure people know they're not going to get their next grant. By or their institution, their research institution says to them, don't say that, don't talk about that, because you might endanger our grant.
Yeah, I mean the the whole Jay Bhattacharya story is
just incredible.
It's incredible. It is an incredible story.
Yeah, the fact that Stanford University, one of the greatest research institutions, would value.
But the incentives, right? I mean the incentives.
That's the incentives.
The incentives. Yeah.
So what we learned is that that system does not. It's not decentralized enough.
Yeah, got it.
And so funding has been flat for the last couple of years. It's going to get flatter. They're going to their proposal is to reorganize NIH.
Now, whose proposal? Getting back
the House Appropriations.
Okay.
Now they actually
put in
the bill. Yeah, we'll go from 27 to 15 institutes, and we're going to fund things in a more holistic way. So there is going to be an institute of body systems. And the idea is that there would be more cross-pollination across that, which could be a very good thing. But what we know about reform in government slows everything down. So not only do you not have great funding picture, you also have a lot of disruption in job titles and time used for restructurings. And if anybody's ever been through a big company restructuring, that's what you're looking at. So we're going to see this headwind for biotech, I think, persist for a fairly long time, unless the private sector really gets in the game again and starts funding, early applied research, and incubates that. And some of them have said that's what they're doing. Sanofi, for example, has said that's going to be our response to that.
Mm-hmm.
But that means you spend more on R&D.
Yeah.
Which is a headwind for biopharma.
Okay, so, that was good. I'm glad we covered that.
Yeah.
Okay. The good. All right, let's close out with the good.
Ambulatory. That's why I put it last.
Yeah.
Ambulatory. So the ambulatory environment is preferred by patients. It is often preferred by doctors. It is definitely preferred by labor. People would rather work in a doctor's office than a hospital.
Yeah.
And they would rather work in a hospital than a skilled nursing facility. This is what the data shows us.
Yeah.
The wages show us that. And if you say to the healthcare ecosystem, all right, we're going to have price transparency, we're going to have site of service optimization, you allow innovation to develop and you allow the ambulatory sector to become more productive and more advanced. Patients like it, docs like it. There's nobody that doesn't like it except maybe the American Hospital Association, and that's a huge plus.
What about home health?
Home health, we can probably put a fork in value-based purchasing as a thing when we start implementing site of service optimization and price transparency, because it was always kind of a political thing. It wasn't really a medicine thing.
Yeah.
But the home health saw a real growth spurt kind of on the value-based purchasing concept.
Yeah.
And what you're doing there really, I don't want to offend anybody, but you're moving the cost of care out of an institution into the home, and you're putting that on unpaid workers, the family.
Yeah.
Okay. And you're not actually waving a magic wand over people to make them better.
No, you're definitely not
doing that. So it exists, and it was successful in an environment where your aged population, particularly before the baby boomers really started hitting their expensive years. Your 65 to 70 population wasn't that terrible. Not that needy. Fuel prices were low. You could accept an inefficient system, which is home health. Now you're in a different ballgame. You've got labor costs are high. Home health is not a preferred site of care for a lot of healthcare workers. They'd rather be in the doctor's office. If they're not there, not be in the hospital. And so it's faced some real headwinds just because it doesn't really work that great,
right.
In a lot of cases. There's a place for it. It's just not, we're not going to see people moving out of getting care in the home like I think we thought under the whole value-based purchasing paradigm that kind of controlled things in the wake of the Affordable Care Act.
Yep. Okay, I buy that. Okay, final question. Just because we're talking about ambulatory, so I'm thinking about all things that are not hospital. What about telemedicine?
telemedicine is slogging its way through changes in the law that I think will be beneficial. It will be, Senator Frist told me this years ago. It is a modality of care. It is not a thing on its own.
Yeah.
It is just one tool in a doctor's
Yep.
in a doctor's toolbox. So but it will continue to advance and dig its way into the system and become a modality, along with visiting the doctor's office, that will drive patient satisfaction.
Yeah.
Okay. Particularly like pediatrics, right?
Yeah.
Who wants to? I know I'm wrong. My kid has an ear infection. This is the third ear infection this
Right.
year.
Right.
Can we just talk about this on the phone
Yep.
instead of taking that poor kid down to the doctor's office?
Yep.
So that is very clearly a win. The headwind is the use of telemedicine in a way that is driven almost entirely by drug prescribing.
Oh, yeah. Well, that needs to happen. I mean, cerebral, dome, global. I mean, like, come on.
Roe.
Come on. Yeah, come on.
Yeah.
Come on. I mean, well, at least Roe is not like pushing Adderall.
No.
You know what I mean? Like,
this is true.
There are levels to this, and some of these people are just really
they became drug pushers, during COVID,
and they're going to jail.
Yeah,
not the Roe guys. I'm trying to be specific here. But the Adderall pushers are going to jail.
Yeah, and they should, because
it's crazy.
And that is a headwind, and I think
that should be a headwind.
And yeah, it should be a headwind.
That should be a headwind.
And if you look out into the future, I think what you're going to see is that telemedicine relationship. There has to be an established relationship,
right? Real one,
not a, hey, I've got a test next week. I need my
stuff.
I need my Adderall, which is what was going down. I mean, and there's several examples like that, but that ultimately is, I think, where and I consider those companies those standalone telehealth companies that are just pushing drugs to be very, very high risk. It's something that will be it'll be in the infrastructure of healthcare,
right?
And mostly invisible to you, except when you want to make a phone call and say, "I got pink eye," kind of thing.
Okay, what did we miss?
Well, we didn't talk about what happens if Joe Biden remains the president.
No, we're going to save that for another week.
Okay.
Look, we got the DNC coming up in the future. We'll bring you back for that.
Okay.
Yeah. No, this is Trump's week.
This is
okay. This is definitely Trump's week.
Yeah.
So we are only covering Trump this week. We will bring you back and we will talk about what. Yes.
We'll talk about that later.
And by the way, by the time that happens, it's unlikely we will be talking about Biden. We will probably be talking about a different candidate.
Yeah. We are living in unusual times.
It is the strangest time I can remember, and I mean, we lived through COVID, and somehow I'm like, this is even stranger.
Well, it's all part of the same thing. It's all the same.
It really is. It's just this whole weird episode of The Twilight Zone that we've been in for years now. Emily, thank you so much. This was fantastic.
Thanks,
I feel much smarter, and I'm going to make some better deals now.
All right, great.
All right, talk soon.
Bye.